Hello everyone, I'm Leandro Siragusa, an Italian surgeon, part of the social media committee of ESCP. And today I have the pleasure to interview a top expert in the field of neurosacral modulation, Professor Klaus Matzel, for the Fecal Incontinence Month. Good morning, Professor.
Good morning. Good morning, Leonardo. Thanks for the invitation. Happy to share some thoughts around sacral neuromodulation with you today.
I know that you are quite famous, but can you kindly introduce yourself for the audience?
All right. So I am a colorectal surgeon working at the university in Erlangen, also in a community hospital in Nuremberg. I have been involved with colorectal surgery for decades. And in the context of sacral neuromodulation, we did our first implant in 1994. It actually was the first implant worldwide done for the indication for fecal incontinence.
How has the role of neurosacral modulation evolved in the treatment of fecal incontinence over years?
Well, it's quite a successful story. It started out as a therapy for a very confined group of patients, those presenting with a morphologically intact but weak sphincter. This was the starting point, and this is a very confined, as I said, group of patients presenting with fecal incontinence. But based on the very positive experience with sacral neuromodulation in this distinct group of patients, the spectrum of indication was expanded over the last decades. And it turned out that sacral neuromodulation is quite a therapeutically efficient therapy for many conditions which lead to the symptom of fecal incontinence. So nowadays, sacral neuromodulation is one of the cornerstones of surgical treatment of fecal incontinence. This is reflected in the recent guidelines, such as the EACP UEG guideline, as well as in the ICI guidelines. And these guidelines, they were published in the last 2 years. And in these guidelines, sacral neuromodulation is considered the therapy of choice, first-line surgical therapy in many conditions, as I said, leading to fecal incontinence.
Are there other indications where neurosacral modulation might be useful?
Yeah, the concept of sacral neuromodulation is that patients undergo a test phase to explore whether the therapy as such would be useful for a certain condition. This test phase turned out to be highly predictive if positive. So we do have an instrument now which helps us to identify patients who might benefit from sacral neuromodulation. The test phase is a low risk, straightforward procedure, not very invasive, and an excellent tool, as I said. And using this tool, of course, new indications have been explored. One of which is constipation. It turned out that sacral neuromodulation is not as successful as expected or hoped for in constipation. So it's not licensed for this indication in various countries. But beyond constipation, sacral neuromodulation has recently increasingly been used for patients presenting with double incontinence, meaning urinary and fecal incontinence, which makes a lot of sense because sacral neuromodulation was initially invented to treat patients with bladder disorders. In addition to these double incontinent patients, there's a high interest nowadays in the use of sacral neuromodulation for low anterior resection syndrome. And the data are not yet matured, but it's very promising.
I know that you have prepared a video that you will share describing a bit the surgical techniques.
The insertion point is cranial to the cross of the vertical and horizontal line of the H. The distance varies and is determined by the distance of skin to bone. After skin entry, the needle is progressed until bone is hit or until the dorsal opening of the foramen, which is covered by a ligament, is entered, which allows for further insertion. Under fluoroscopy, the foramen needle is advanced until the ventral cortex of the sacrum. When at the correct level, a test stimulation is performed, aiming to achieve motor response of the pelvic floor and anus, or sensory response if the procedure is performed under local. Forefoot response is also checked. In this case, motor response using S4 did not produce the desired results. A second needle was inserted into S3 following the previous steps, and a test stimulation was performed with success. A typical bellow-like movement of the pelvic floor and optional plantar flexion of the forefoot. The redundant needle in S4 is then removed. A 1 cm incision is made at the entry point for the introducer to be inserted. The incision is large enough to insert the tunnelling device once the electrode is placed, without damaging the fixed electrode. The foramen needle stylet is removed and the directional guide is inserted without it advancing beyond the depth of the foramen needle tip at the ventral cortex of the sacrum. The foramen needle is removed, leaving the directional guide in place. It is important that the guide is not pushed when removing the needle. The white dilator is inserted over the directional guide. Ensure that the directional guide does not advance into the pelvis while pushing the introducer, and that the tip of the introducer is not beyond the ventral cortex of the sacrum. Too deep a placement of the introducer may create a false path. Fluoroscopy is advised to monitor advancement. Once the introducer is correctly positioned, its inner metal part along with the directional guide are removed. The white sheath with the radiopaque marker remains in position. The marker should be in the foramen. The tined lead carries 4 electrode contacts, 3 mm each spaced at 3 mm apart. The electrode is numbered 0, most distal, 1, 2 and 3 most proximal. Our aim is to position all 4 contacts in close proximity to the target nerve. The flexible curved stylet is used to follow the natural path of the nerve. With the introducer sheath in place and radiopaque marker inside the foramen, the electrode is then inserted with the curved tip pointing laterally and caudally. As the first white marker reaches the introducer's upper edge, all 4 electrode contacts are still covered. Gently push up to the second marker or until resistance is met without applying force to exit all contacts off the introducer. The tines remain in the introducer undeployed. Use lateral fluoroscopy to ensure the most proximal contact is at the level of the ventral cortex of the sacrum. After proper insertion, the electrode deviates laterally, giving the impression that the space between the distal electrodes is less than the proximal electrodes. A test stimulation is then applied to each contact. Ideal placement is achieved when the proper stimulation response is evoked at 2 mA or under. Concurrent forefoot motor response is only acceptable if occurring at higher stimulation intensities than for the pelvic floor and anal motor response. The electrode is held in place as the introducer's sheath is retracted so that the electrode placement is unchanged. Once the sheath is removed, the tines deploy, anchoring in the surrounding tissue. Fluoroscopy is then used to confirm position. Perform a test stimulation after sheath removal. If the response is correct, both the electrode stylet and introducer sheath are removed. Once the introducer and stylet are removed, the electrode position is again confirmed by fluoroscopy and stimulation.
It is an edited video, but the procedure as such is not a very time-consuming procedure. It usually takes around 45 minutes altogether.
What are the future perspectives for neurosacral modulation?
I think the future of sacral neuromodulation is a very bright one, I have to say. We now have a technique which is very evolved, low risk, and allows a patient treatment with a high degree of reliability. The clinical effect is sustainable. The longest follow-up is now, as I said, the first patients were implanted in 1994. It's 30 years, and it's a sustainable therapy. Also, you have to exchange the pulse generator because of battery depletion. The therapy remains the same, the therapeutic effect. So where do I see the future? I see the devices becoming smaller. I see the battery capacity increasing, which reduces the need for battery replacement. Conceptually, I think it would be very interesting to have devices which do not stimulate in a continuous manner, but have an inbuilt feedback mechanism, which is then more a stimulation on demand. And then, of course, other locations are very interesting for neurostimulation, such as the pudendal nerve, such as the posterior tibial nerve, which has been explored for treatment of fecal incontinence and was not very successful. But I still think there is potential there to make use of this approach. And then, of course, there are a lot of nerves in the pelvis which could be stimulated directly via minimal invasive implantation techniques. So, as I said, the future is bright and very promising.
No, it's interesting to see that even if it has been on the market for a long time, there is still so much work to do. And many thanks for providing your insightful comments and for sharing the beautiful video.
Thanks again for the invitation.
Yeah, it was a great interview. Many thanks for agreeing to participate, and hope to see you in Thessaloniki.